Amy.
As the William and Joanne Chair of Nursing Research here at Children's National. And I am so happy to share with you the purpose of the Conway Chair Conversations. And part of that purpose is to bring researchers, non-researchers closer together, particularly clinicians, so that together we can really design research that is practical, feasible, and acceptable to our families, and that will most definitely advance the health of children and their families, as well as our communities and each other. So I want you to know that we have Conway scholars that are hosting today's meeting. And in particular, I'd like to call out Dr. Lisa Ring, Dr. Vicki Friedenberg, Eileen Eng, Mr. Duran Wilson, and Dr. Randy Streisand. Today, Dr. Lisa Ring will be doing introductions of our lead conversationalists. Please recall that you too have a role here, and that is that you are also conversationalists. We then are challenged as those who listen to our two lead conversationalists to come back with our thoughts, our opinions, ideas, even recommendations. I look forward to learning and listening to each of you. Please, if I may, remind you that you are fully able to get credit for attending today's conversation, and you will please look in the chat for the link to help you get that credit. May I please welcome Dr. Lisa Ring for the introductions of our lead conversationalists. Lisa.
Good afternoon, everyone. I'm so excited to introduce Dr. Saran, who is an assistant professor of pediatrics at the George Washington University and an attending neonatologist at Children's National Hospital. He is the director of education for the Division of Neonatal Perinatal Medicine and the director of education for the hospital-wide simulation program. His research interests are in simulation, interprofessional education, adult learning, curriculum design, and medical technologies. He recently graduated from the Master Teacher Leadership Development Program and is enrolled in the Master's Degree Program in Education and Human Development at the George Washington University. He completed his medical school training at the Rutgers University Robert Wood Johnson Medical School in 2012. He completed residency training at NYU Bellevue Hospital at the NYU School of Medicine in 2015. He was then accepted into the Neonatal Perinatal Fellowship Program at Children's National and completed his training in 2018. May I also introduce you to Heather Walsh. Heather has served in a variety of nursing roles at Children's National Hospital since 2000. Heather is a certified pediatric nurse, pediatric clinical nurse specialist, and healthcare simulation educator. She completed the Master Teacher Leadership Development Program in 2008 and is the first nurse member of the Children's Academy of Pediatric Educators. She worked as a unit-based nurse educator before joining the simulation program in 2012, where she currently serves as the simulation program manager. Heather is a scholar of the 2014-2015 cohort of the National League for Nursing Leaders Development Program for Simulation Educators. She is consulting with the National League for Nursing to review and update pediatric simulation cases, and Walters Kluwer as a subject matter expert in revising the pediatric virtual simulation curriculum. Heather is a second-year full-time student in the nursing PhD program at the George Washington University and is excited to complete her coursework this semester. Thank you.
Thank you so much. We actually have a message we'd like to share from Dr. Newman, which I'll load up right now.
In June of 2020, I challenged the simulation program at the ACGME Steering Committee meeting to create a training program that focused on one of our biggest challenges, the DEI challenges that our country and our community were facing. Out of that came the iDream program, which is helping to support all of our staff when they encounter racism, bias, and microaggressions. I feel it's important to create a space for our teams, our employees, to share their experiences and thoughts on racism and how we as an organization and as peers and colleagues can come together to enact impactful and meaningful change. We're better off as a people when we engage with each other, learn from each other, and demand better of each other and our institution. That's why I'm so proud of this novel and just amazing iDream program and the number of our team members and employees who have already participated in the program. It's how we address the down cycle effects of racism and bias in our organization and country. It's how we build a more diverse, equitable, and inclusive Children's National. So please keep up the great work. Keep getting people signed up for this training. It's important to who we are and who we want to be as an organization and a healthy system. Thank you.
So we definitely want to thank Dr. Newman and many others in hospital leadership before we get started for their support as we've been working on this training and our project stemming from it. That includes Dr. Newman, Dr. Cora Bramble, so many others in leadership who've been directly helping us and helping us move this forward. We'll get started by talking a little bit about our learning objectives today. So after today's session, we'd like you to be able to discuss curriculum design for large-scale interprofessional education, similar to the iDream training we'll be using as a vehicle for that, and discuss educational research projects arising from such large-scale trainings, with an overarching goal of creating a more inclusive community here at Children's National. Before we begin, we'll just start with some definitions just to make sure everyone's on the same page. These are definitions that we actually share with our learners when they sign up for our training. So the first is racism. This is the belief in the superiority of one race over another. A term that I'm sure we've all heard very often. This can result in discrimination, prejudice towards people based on their race or ethnicity. So that discrimination would be the unfair or unequal treatment of an individual based on certain characteristics such as race, ethnicity, age, disability, gender identity, sexual orientation, religion, etc. And then microaggressions are brief and commonplace verbal, behavioral, and environmental indignities, whether intentional or unintentional, that communicate some sort of hostility or derogatory comment or some assumption about a group of people that may have unpleasant impact on that group. And again, these can be on the basis of race, income, ableism, gender, immigration, or a multitude of other characteristics. Then we have unconscious bias. Unconscious bias refers to beliefs and prejudices that we hold that reside outside of our awareness. The microaggressions are then the result often of unconscious bias. And inclusion is specifically the process by which individuals view themselves as active members of a larger community, where their backgrounds, insights, and contributions are valued as a part and creativity and productivity of that group. So just to give a little bit of history of hospital-wide simulation-based training here at Children's National. So the initial large-scale training was done actually before I came onto the simulation program. So Heather, please join in if I misspeak here. We initially started with code response training, which focused on safety language. That was in the 2016-2017 year and was done in person. The next iteration of this was in 2018-2019, termed adaptive response training. Again, in person, focusing on event reporting. The third iteration was going to be third iteration or second iteration, I don't know which one that is, was supposed to be in 2020, again, in person, revolving around, if I remember correctly, sepsis and response to sepsis. And unfortunately, that had to be completely redone due to the pandemic. And it was during that time, during that summer, that we were issued that charge by Dr. Newman. And so that was the impetus that led us towards iDream, the Interprofessional Debrief on Racism, Equity, and Microaggressions. For that the name and mnemonic, I'd like to give credit to Dr. Agarwal, who had a multitude of wonderful ideas, but we settled on iDream. And the focus of this was to respond to help our employees respond to microaggression. And this was an undertaking that we took as a simulation program that didn't necessarily have any expertise in this field. And so we started to look at how we would actually deliver training such as this. Next slide, Heather. So this is one of my favorite slides, charts as a curriculum design wonk. This is from the 6-Step Approach to Curriculum Development, a book by Kern. If this is something you do, and as part of your work, I highly recommend it. It's a very nice reference, as well as a good read. So what I like and what I get from this figure is the circular and the iterative nature of this process. There are yes, 6 steps to curriculum design. However, they're all related to the others, but can yet still be done in a cycle. So, starting at 1 that summer of 2020, our problem identification and general needs assessment was essentially done in many ways through the work that the hospital had already been doing through our DEI initiatives. So we took a lot of that and moved right into a targeted needs assessment, looking at who we wanted to be our learners, what type of environment we'd be learning in. So of course, one of the significant changes to this training was that it would be delivered virtually and essentially completely virtually. So once we had that design, who we wanted to approach, that we wanted this to be interprofessional, include nurses, doctors, so many other staff members that are all clinical facing in our hospital, we moved to our goals and objectives. And this is where I think having a process like this in place was quite helpful to us. We were very self-cognizant that we were not content experts in this field, and the number of content experts available to us were limited. So we took that and we looked at what we wanted to have our learners get out of this training. And that's where we came up with our specific measurable objectives. And we focused on things like knowledge, skills, and attitudes, providing some baseline knowledge, nothing that would necessarily require a content expert to deliver. Baseline skills that we could also discuss through our expertise as simulationists, using the debriefing tool that we are also familiar with, and trying to change attitudes in doing so, which is, I think, one of the most interesting things that we hope to see as we continue our studies. So we decided that the overall broad goal of this training was to start a discussion, give some basic information, give some tools for responding to microaggressions, but really get an interprofessional group together and get them to discuss scenarios that were intentionally broad and could allow the learners to trigger things within themselves so that they could serve as their own educators in this debriefing model. We then moved on into our strategies, which, as you can see, kind of melded together there. And then implementation has been an absolute labor of love. I'd like to take a moment to really thank the simulation team for the tremendous amount of work and effort that's been put in doing this, in scheduling, in making sure these are interprofessional, in discussing with all our hospital leaders who have been, again, extremely integral in getting this out to all our learners at the division level and managerial levels. Then finally, we have evaluation and feedback. So if I had to pick a certain point where we are currently implementing as well as evaluating. However, again, going to the circular nature of all this, while it happens less often, almost every week now we learn something new about this training that requires us to go back to our either needs assessment, our goals, or our strategies, make an adjustment, whether that's how we facilitate, how we communicate. And so we've been continually going through this process over the past year, even though now our focus is on steps 5 and 6. Before we go through here, and any questions or anything unclear before we move on to the next slide. And again, please feel free to use the chat or raise your hands. Okay. This is another great slide that came from Master Teacher from Ellen Goldman, who adapted it from this citation here. And this is a combination of looking at learning objectives as well as teaching strategies and breaking it down by cognitive processing levels. So I like the staircase because it takes you right through the process, and this is what we use in creating our learning objectives. One, we look at cognitive processing levels. Remember and comprehend are often the levels we think of at baseline learning, being able to list something, define something, describe something. Typically, when we're looking at adult learning, we often want to make sure we get towards the higher parts of that staircase: apply, analyze, evaluate, create. And what you can see is the learning objectives for those things are things like performing something, interpreting something, differentiating, judging, hypothesizing, planning. And simulations and discussion are some of the best learning modalities to do so. And so this, we realized that once we, even though our learning objectives were more on the mid-level here of apply and maybe analyze, simulation is a fantastic way, especially debriefing, to achieve these learning objectives that we created. Next slide, Heather. Thank you. Another infographic that I like to rely on, and that we relied on quite a bit when developing this training, was the learning triangle from Illeris. So oftentimes when we create a new educational modality, we tend to focus on what we're comfortable with, and that tends to be the content. This is a valuable dimension of learning. It's absolutely necessary. And often as folks who are teaching something we know, or at least somewhat comfortable with, we tend to focus too much on content. I'd say in developing iDream, again, because we were not content experts on racism, microaggression, or any of these things, we were almost forced to make sure that we looked at the other dimensions as well, the incentive and the environment. So this came into play with the way we set up the training. So there was a limited amount of pre-work. This kind of goes towards the incentive dimension. We know that, it wasn't just the pandemic we were dealing with, especially in early 2020, but as it's continued, what's gone on in the social climate, the surges that we've had, people dealing with personal things with COVID, we wanted to be cognizant of the burden we were placing on people, because the incentive to do a training like this may not be there really at this moment in time. And so we decided to very much limit our pre-learning, again, keep to more broad scale, not broad scale learning objectives, just specific learning objectives, but non-intensive learning objectives. And we wanted to make sure this was done interprofessionally, outside of necessarily groups, so that people would be mixing from their units. That goes now more towards the environment. Again, realizing that this was going to be done over Zoom. The length of the training could not be too long or too short. We understood that we were asking people to now likely maybe come in on their day off, or give us an hour of their time. And so we were cognizant in developing all those. And I think the key here is just a reminder to look at all those things. Look at what the incentives and motivations of our learners are. Look at the environment through which we were teaching, but then also look at the content we were delivering through that modality. So this chart then goes over a few of the challenges and resources that we were able to utilize when we developed a training such as this, intended to go out to up to 3,000 learners over the course of 6 to 8 months. So the one that we've already discussed a little bit was the lack of content expertise. The way we were able to mitigate this was by, one, really deciding what we wanted our learning objectives to be. We had tremendous support from leadership, as I mentioned, and then we decided to lean on our strengths. We did not try to create a educational module or an educational activity that would need us to lecture or to describe topics that we were not experts in. Instead, we said we were simulationists, and we know how to get people together, and we know how to run a simulation, we know how to debrief them. And so we focused our time on creating a simulation that was intentionally broad, and then having a facilitator guide that would allow the learners to do 80% of the talking during these sessions, and move the discussion forward that way. Leadership also put into place very specific modalities and committees, of which Heather and I are part of, such as the DEI committee, but also other general committees, such as the curriculum development committee under that auspice, that have been helpful in meeting these goals. The second issue that we faced was lack of an existing roadmap, and this is what makes kind of Heather's part of the talk very, very interesting as we go to study this, because there really is a lack of a roadmap to do something like this. So again, we leaned on our interprofessional teams to make sure we were watching our own blind spots, as well as having a diverse group. Our study group is, I think, over 8 or 10 individuals coming from different professions, different units, different backgrounds in the hospital, and that's been incredibly important. The existence of multiple required curricula was the next issue we faced. Obviously, and many of you may be doing your cornerstone training now. We wanted to make sure this was integrative and not going against that. So again, that also moved towards going back to our 6 steps. We didn't want our modality to be the same as a cornerstone module. And then we had early inclusion of our stakeholders, which also we worked closely with those who help run our cornerstone modules to make sure we were not running against them. And then finally, the scope of this, a rollout to 2,000 plus learners, potentially up to 3,000 learners. And that's where we had to carefully develop our processes, create redundancies. And even so, as I mentioned earlier, we really needed to reevaluate many of those things as we moved on. And I don't view that as any sort of failure, but rather that's just the iterative nature of running something this big. So a little bit more about the specifics of iDream. So this has been rolled out to all patient-facing clinicians across various professions with a max of 14 learners per session. I think we've been averaging somewhere around 8 to 12 per session. These are 1-hour sessions on Zoom with 2 trained facilitators, one from the simulation program and the core iDream team, and one from our hospital-wide set of facilitators who've been fantastic. As well as a person serving in a technical support role, which has been extremely valuable in this type of modality. We've set up expectations for a safe learning environment. Again, many of the things we do discuss in our normal simulation sessions. And then we have 2 5-minute videos, which then result in a 2 debriefing discussions. The first video, briefly, without giving too much away to those who may not have taken the training yet, goes over language barriers in the hospital and an escalating medical situation. And the second scenario is a series of microaggressions that one might see in the hospital or in the workplace. And then we ask learners to share their takeaways. And it's been extremely rewarding. I think I've learned so much as a facilitator, and we all have from attending these sessions with our learners. And it's, I think some of the comments that we've gotten early on have been extremely and overwhelmingly positive. And then the key takeaways that we'd like you to take from this part of the talk, at least, are that you can develop large-scale curricula. It's difficult, tedious work, but it is rewarding. I think the more difficult something is, definitely the more fulfilling it can be once it's put into place. If going into some of these types of content matter that you're not comfortable with, lean in on what we know so that we can safely push that comfort level. And then use the resources that are available to us, and definitely use a design methodology to do this. That not only improves our processes. This is how we were able to increase our opportunities for scholarship by having specific measurable objectives, which we could then assess, and that opens up those doors. And then the team. The team is tantamount to everything here. Having a diverse team, folks with multiple levels of experience and different backgrounds, not just professionally, but socially, economically, top to bottom. That has helped us create something that I think we're all very proud of. And we'll go over this and then I'll pass it on to Heather. So this is the actual model that we've been sharing with our learners. This is kind of the one bit of teaching that we do. This is called the OWTFD model, and it's in the literature as a model to respond to microaggressions. And so it doesn't quite roll off the tongue, but it gets the point across. We like to tell our learners it's a lot of I feel statements, a lot of self-centric statements, that in a world where we're discussing assumption, we don't want to assume what anyone in a situation is doing. And so it encourages learners to, if they see something happening, to approach with statements such as, hey, I noticed something happened, and asking a person what they meant when they said that. Then focusing on what the person felt and thought about the situation. Finally, asking the microaggressor, or even the victim, if they're discussing with someone, maybe what a right path forward would look like, at least from your standpoint. And that way we're not further making assumptions. And I know Heather will discuss more about this paper from which we received this model, Soto Santiago et al., because that's also been integral in our assessment as well.
If I could just add to this slide, as we're debriefing these sessions, time certainly comes up. What is the appropriate time to address a microaggression? Some scenarios may not be appropriate, for example, on rounds. And so I think there's a lot of discussion within our groups and advice maybe on people who have addressed microaggressions on whether, you kind of, the time is you just stop and address it at the time, or you kind of pull the person aside later. And so I think there's a lot of variability and a lot of in comfort for people, some of it having to do with even experience, where we've had some folks say, I'm a little bit older now and I feel more comfortable saying things as I would with my own children. I would kind of stop and address the behavior in real time. And certainly power differentials come into play, where trainees or more junior staff might not feel comfortable if the source of a microaggression was, for example, an attending or a superior. And so those are kind of challenges that we're working through in the course of having these conversations as well. Dr. Wallington, looks like you had a question.
Oh, sure. Good afternoon, everyone. I'm one of Heather's professors at GW in the School of Nursing. So, and Heather, I'm not sure if you're going to cover this later, but I addressed this question to you and Simran. How did you assess mastery of the core competencies?
So we haven't yet.
Yeah.
Yeah. Well, I think I'll be touching on that, I think, as we get to some of our educational scholarship.
Okay, great. Thank you.
No problem. Okay, so let me move on to the next one. So just going over iDream by the numbers, as of yesterday, we've had 1,339 clinicians participate, with an additional 600 signed up to attend the training. And for me, having been involved in the previous 2 rounds of hospital-wide training, we had 1,400 and 1,600 in our previous 2 rounds. So I think we're on track to probably exceed 2,000 learners, which is really exciting. And we've also had a larger mix of clinician groups in this round, which has been really fun, learning with groups that you don't typically learn with. So we've had, our usual nurses and physicians, kind of early adopters, but we've had child life specialists, art and music therapists, audiologists, speech and language therapists, psychologists, admin staff, our PCTs. And so it's been really cool to kind of learn with such diverse groups of learners, from folks who are at the front desk, kind of all the way through the healthcare system. We started teaching these sessions or facilitating these sessions in October, and they're scheduled to run through June of 2022. Just as some reminders to staff, we talk about some of our resources. Simran mentioned the 2 scenarios that we focus on, and we review the different kinds of interpreter services that we have available to communicate with our non-English speaking families. And we in particular focus on the first one, which is a phone number that can be used from even your personal cell phone as kind of a useful device when people are trying to search for maybe a MARDI, or they're waiting for an in-person interpreter. Everybody has their phone on them. And so that's kind of a quick resource to access an interpreter immediately for speaking with a family. And then I had mentioned earlier about the power differentials. And so the safety event reporting system has a tool, a bias reporting tile that I have a little picture of here. And so we encourage staff, if they feel uncomfortable speaking up with somebody who may be a superior, if there's a power differential in play, that they can report these events either anonymously, or they can do it as themselves, which would allow for follow-up. And I see Dr. Corbrambles on here. We say your name in every one of these sessions, that you and your group review these, and they're taken very seriously. So we put in lots of plugs for that. And I feel like those 2 things, not knowing about the language line and the safety event reporting, have been kind of 2 aha moments where a lot of people were not aware about either of those resources. And then we wanted to show this kind of just a preliminary learner feedback, which we thought was really interesting, because we put it in the kind of the arrow formation as kind of showing the way forward. But you can see some of they're weighted. And so some of the ones that have kind of bubbled up to the top is just some preliminary feedback from our staff. In terms of educational research, so immediately, I think probably our first study that from this extensive curriculum is we're doing a pre-post. So we have a baseline survey that people complete ideally before the class, or if they haven't, we give them an opportunity at the beginning of the session if they desire to complete the survey that they can complete the survey. We do an immediate post survey and then a survey 3 months following the training. And so we've already been doing those 3 months out from the people who started in October. And so I think, being able to show over time, we've created unique identifiers for staff. And so you could actually make up your own unique identifier. So I think one of the challenges there is if people don't remember their unique identifier, it might be hard to link the surveys, but they can be linked based on that unique identifier, which will allow us to look at trends over time. And then the tool, Simran had already mentioned Soto Santiago, and I have a picture of kind of the first couple of questions on the tool. We reached out to them and were able to get permission to use the tool, but they have not previously done any psychometric testing on the measure. And so I think that that's a really great opportunity for us, maybe a little bit further down once we get some of these other papers out that I think maybe a little bit more in our comfort zone. I think tool development is not really something that we're expert in, but certainly are interested in collaborating with a psychometrician or a statistician to be able to run some statistics on the tool. And then another study can be a thematic analysis. So as facilitators, we basically run these in blocks of like a 4-hour morning or 4-hour afternoon, 2 sessions in a row, then a break, and then another 2 sessions. If typically we'll have like different sets of facilitators for the 2 different sessions, and we complete a facilitator tool. And so these are just some of the questions, I think kind of the 2 primary questions that we're just collecting data on as facilitators is anything that may have stood out for us in the session. And some of these also lead us to escalating maybe some challenges to leadership in terms of resources available for interpreter services or any microaggressions that we kind of thought stood out to us. So I think there's a great opportunity to do a thematic analysis of all of this rich data that we're collecting from a facilitator standpoint, which is all de-identified and anonymous. Then another one that had come up and I feel like this is a perfect venue to share this information. We quickly realized, so when we finish any of our simulations, we ask for takeaways. And so the beauty in asking folks to share their takeaways is that number one, as an educator, you're reinforcing that people have learned something. But I think second, you're able to see the variety in what people have learned from the group. So we can all be at the same simulation or same session and all learn something very different. So I think that's always very rich to kind of hear from other people's perspectives on what they learned. So really from the first week, we identified that these takeaways were kind of like a hidden gem that we hadn't anticipated studying. And so they're not currently included in our exempt IRB, but I think that we're interested in pursuing a second IRB to be able to use the takeaways that we capture in the sessions. And then near and dear to my heart will be my dissertation project. So as I've come in as a kind of a novice qualitative researcher, but really love understanding people's experiences in terms of what they learn. And it's very difficult, as we know, to evaluate education, but I think qualitative is a beautiful way to do it. So my working research question as of today, which is probably subject to change tomorrow and every day moving forward until I get to my proposal, is really understanding how does participation in DEI training impact healthcare providers' observable response to microaggressions, and really from 3 different perspectives. So as the recipient, as the source, and as the bystander. And so my plan really is for this summer to submit an IRB, to draft my interview guide, and to conduct some pilot interviews. And then in the fall, I should be defending my proposal and can begin recruiting and interviewing with a team we haven't yet identified, but it will largely be some of our simulation folks and some of the facilitators that are helping with this training. And if everything goes according to plan, our team will really conduct the interviews, analyze the data, and then just work on dissemination of our findings. And I just wanted to share, it's really important to have a conceptual framework to undergird this study. And so here's the microaggressions triangle model, which examines microaggressions from those 3 perspectives as the source, the recipient, and the bystander. And so we talk about this in our class that at any one point, you can be the recipient, the bystander, or the source of a microaggression. And the video actually starts with a father making a comment to a nurse, which is kind of meant to be a compliment, but kind of comes off to the nurse as a microaggression. And then it finishes with somebody microaggressing the father. So it kind of shows that circular nature that we can all be on the giving and the receiving end of a microaggression. So using this model will allow me to focus on those 3 different perspectives for each individual. And Dr. Ackerman Barger and team had kind of used these acronyms that we don't focus on in our training, but to be able to provide scripting when people find themselves in that scenario. So when you're in the bystander, you can use arise. When you're the recipient of a microaggression, you can use action. And then when you're the source, you can use assist. And so I think the scripting is very similar to what we use with the OWTFD model. I think it gets to the same gestalt of using the I feel statements and kind of offering suggestions of how we can move forward beyond the microaggression. And then very simply an apology if you're the source of the microaggression. So at this point, I would like to stop so that we can have plenty of time for comments and feedback. And I would just like to echo what Simran has said earlier and really thanking our simulation team. Some of them are actually doing a simulation right now and we're not able to attend. But we have, I see Rosalind on the call and Simi Kang and Devesh, who have been leaders and integral in supporting us to facilitate this training, as well as some of our unit folks who are helping to facilitate it as well. We really appreciate it. And then I really wanted to acknowledge and thank some of our faculty from GW Nursing. You've already seen Dr. Sherry Wallington, Dr. Juliana Gonzalez-McLean, and Dr. Laurie Tiki. So thank you all so much for attending, and we look forward to fielding any questions and importantly, getting some feedback from this group of scholars.
If I may, to both you and to Simran, I've been involved in the periphery of this and was a bit of a sounding board as it relates to the work that we're doing in one of the DEI subcommittees. And I'm just so pleased to see the development of all of this. I think that it can easily become a national model. I'm not aware of a lot of other simulation-based training for DEI. So I do think it's rather innovative. And I just want to congratulate both of you. And Simran, I know that you have been just persistent. After your baby was born, you just kept at it. And I just wanted to give you my heartfelt congratulations for a job well done. I'm so pleased in terms of what I've seen so far and look forward to the final results.
Thank you so much for those kind words. And I just have to turn around and really just again, say thank you to our team and the support of you and everyone else in leadership that has really enabled us to do all of this.
Hi. Oh, sorry, Dr. Hines. So I first, I think, and I'm not sure if I see Pavan on here. I don't think I do.
He was working last night in the
I thought so. I wasn't sure if he was going to be able to attend. So just, Pavan and I co-lead the simulation program and really just the depth and the breadth of this work is just really outstanding, and really want to congratulate Simran and Heather. Really have led this work just with such intent. And I think that that's a really important word here, because they've been very, very careful to make sure that the quality of this work is aligned so well with our organizational goals and objectives, but more so with really being mindful of how to carefully approach a topic that is extremely sensitive, and have done so in a very, very, very an important way, and in a way that I think has resonated with all of the participants. I've been a facilitator myself. Pavan and I and Devesh have worked with Simran and Heather as they've developed this content, the facilitators guides, selected the methodology, selected their frameworks, thought about it from a theoretical perspective, an evaluation perspective, and really they've done an exceptional job. And I'm so glad that they were able to start to showcase this work. They have some national presentations coming up as well. And I think, Dr. Wallington, you asked earlier about competency. I don't think this work is going to live in that space just yet. I think that as we learn as educators, what are DEI competencies? I think we're still figuring that out in terms of what is going to be foundational core competency for DEI. But I think that there's components of DEI competency that we have been measuring and assessing and evaluating in our clinician behavior. So I think now is an opportunity to start to put it together. And I think Heather's on her way with this bystander source recipient PhD work that she's going to do. And we're going to continue to get some good outcomes from that work as well. Really, really well done, Simran and Heather.
Heather and Simran, this is Pam. And may I ask you, were you surprised by anything that has emerged from this work? Anything that you were surprised enough by that you might formulate a research question to pursue?
The first part of your question, I think definitely been surprised by things. I think the research question one, I'll take the easy part, Heather, and you talk about the research. How about that? I think absolutely. I think the one thing I've been surprised by in general was, I think the level of willingness to share in an open setting, in an interprofessional setting, in a setting where there may be folks that you report to directly or indirectly by chance that are in the session, or or folks that are already in very high leadership positions, and really opening up about times that they realized they made a mistake. That some of the most powerful, again, without giving anything away, just some of the most powerful statements that I've seen have been those, and then just personal testimonials, whether it was at work or outside of work. I think what I like about this training is that we are not marching out there. We did not create a module to say, hey, look, this is what happens to a person of color or so and so, and let's talk about this specific event. We rather we need learners to describe what is happening to themselves for this to work. And the fact that they've been doing it, I think, one, makes no two sessions alike, but two, really makes the sessions powerful because it's a personal story now. It's one of your coworkers. It's not Heather or I or whoever was facilitating that day talking down at people, wagging our finger. And I think that's what surprised me the most. And maybe that I think actually is one of the things that I think has resulted in Heather going down the road she has. Any thoughts on that, Heather?
I would just add to that. I think, the word microaggression is not a new word, but I think it's a word that a lot of people are unfamiliar with. And so that's why we kind of wanted to share some of the definitions, just to make sure that everybody's kind of starting out on the same footing. But people's ability to recognize a microaggression, and I think we'll see this probably in our data where we ask in the pre-survey and the post-survey, once you watch a video, you don't necessarily think that calling somebody sweetheart is a microaggression, but it is. And so I think in our series of microaggressions that we demonstrate in our video, there's a lot of microaggressions that I think people may be having a different perspective and then saying, I've actually done some of those things and I didn't realize that they were microaggressions, or I didn't realize how somebody else might have interpreted my actions or my behavior. I also think in terms of responding to microaggressions, we've heard so many interesting stories that were kind of surprising to me, where people who are what I would perceive to be senior physicians would not feel comfortable saying something to a trainee, which was very surprising to me. They would feel more comfortable saying something to a peer. And so I think having these conversations is really important, just kind of giving people permission to speak up and giving them some language. I think a lot of people have appreciated learning the OWTFD model as a framework for how to have that conversation in a way that won't allow somebody to get defensive. And that will be kind of a restorative way so that you can continue to have a professional working relationship. And then lastly, I would just say doing this on Zoom has been surprisingly cozy. And everybody kind of feels they're in their own little safe Zoom square. But I think because of the class size and the nature of how we share the safe learning environment expectations, that people have really said that they felt comfortable and kind of in a nice supportive environment to share the stories that Simran referred to.
I think I see hands from Dr. Wellington, and there was another hand.
Oh, yes. Simran and Heather, just congratulations on this great work. But just to follow up, I think it was Simi when I asked the question about core competencies. This is really a great benchmark for you to build from. And I hope you will even publish from this first, preliminary work. But one of the competencies I immediately thought about was increased awareness. And part of, I think, the issue in these discussions, which can be difficult sometimes, is that many people are unaware and they don't have the training, the motivation to even have discussions about it. So increased awareness is the first start. And then I was so excited to see when you talked about, Heather, how you define the terms, because naming things is so important to increasing awareness about these concepts. And so, congratulations on this great work. And Heather, I look forward to continuing to work with you on your dissertation.
Likewise, thank you so much.
Thank you for sharing that. I think that also triggered one of the other things. I think one of the moments that stands out oftentimes, I think, in the training is when we tell people that implicit bias is in and of itself not a bad thing. It's part of the human condition. And so the dad joke I always share is, if I was in the woods and I saw a bear, I would be very biased towards that bear, that I wouldn't have to think about anything before my heart rate jumped up. I just, looked for a way to exit that situation, made all these judgments about what this bear might do to me, regardless of what that poor creature may or may not want. So we all have these biases based on who we are, how we were raised, the things that we witnessed. And the problem becomes when we take those, our brains work the same way in a social situation. And there you can't look at, for most of the time, you don't want to be looking at a person and come to a snap judgment of who they are and then act on it. And that's where the microaggression comes into place. But bias in and of itself, we shouldn't be looking to rid ourselves of implicit bias per se. That happens over time, but it's rather being aware of our own biases so that we don't act on those biases and slowly change our perception over time. I saw, I think, Eileen's hand as well, and then B.S. Brown.
Thank you, and thank you for this presentation. Because you both have mentioned how important the safety of the environment was in terms of creating kind of a productive training, have you thought about asking the question of what were the antecedents within the organization that created a space where you were able to actually get into like affective learning behaviors? And could that be one of your research questions?
I don't think we thought about that, to be honest. I think to Simran's point, this was not anybody's, this was not our area of expertise. But I think we spent a lot of time really trying to create a curriculum that would be engaging and interactive and interprofessional to address, to start to have the conversations around DEI. I think we can certainly consider that.
Yeah, I could see maybe how that could work into if we're doing a qual study of learners as to were there things that allowed them, what allowed you to share or not share. Mm-hmm. I don't know if that points in the same vein as that. That's very interesting.
Hi. Yeah, this is Barbara. Listen, I was just thinking about something I think Heather may have said about, microaggression, and sometimes we might make statements or comments that we're not really aware that they are. And it made me think about some things I say sometimes. And do you ever think that some of these things may be cultural? And I know being from the South, there's, I might say honey or, or sweetheart or, something like that when it's just, part of my upbringing. And then I know from different cultures too, patients will even call me ma, especially in the African culture, they'll call me ma, and I'm like, sometimes I'll sit back and like, ma, you're insinuating that I'm old or, but do you ever take into consideration the cultural perspectives when you're thinking about microaggression?
Absolutely, Barbara. And we also talk a lot about impact versus intent. Right. And so I think the impact for you is well-meaning and well-intentioned, but sometimes that's not always the case. And so I think if you, depending on who you called sweetheart or hun or who called you mom, it might come off differently to you. And so I think it kind of depends on the recipient's reaction to it and how they feel, or maybe even the bystanders. So maybe you call somebody sweetheart and somebody else would say, that doesn't really seem appropriate. But the person that you're saying it to is okay with it. And the two of you have a good working relationship. And so there's no harm intended. So we do talk a lot about the context in the relationship. when it comes to those comments. And certainly we've heard a lot of folks from the South who call everybody honey and sweetie. And, I think a lot of us as clinicians too, we might call the parents mom and dad. And so we have conversations about that, and that can get us in trouble if they're not mom and dad, or they're mom and mom, or their next door neighbor and, random visitor. And similarly, we might call our patients names.
Right, and thank you. It'll just make me more aware, Yeah, thanks.
Yeah, absolutely.
And that's, yeah.
No, go ahead, Tim.
Oh, I mean, I was just gonna say that's absolutely correct. I think that's the exact take, is that most people, I do think that if it's brought up nicely to us that, hey, maybe you shouldn't call, X, Y, and Z, I think majority of people would actually be like, oh, you know what? I did not even realize I was doing that. Thank you for bringing that up. It goes back to that whole thing of like, we don't even like telling people when they have something in their teeth. Like, and here we are trying to ask people to call out our microaggressions for us. And so it's difficult. It's absolutely difficult. I think it's, again, human nature to avoid confrontation most of the time. But that's where we talk about individual leadership to our community, and that it really is up to us to be self-reflective, and in appropriate situations, charge each other as bystanders to potentially be willing to say something. I think the one thing we're very clear is, while a victim may choose to speak out, it is never incumbent on the victim to educate their aggressor. But the other two of the triangle, I think in certain situations, absolutely, and especially self-reflection. If we can teach a little bit of self-reflection, that goes, I think, a mile.
I just wanted to say, as a participant in this simulation, as a human being, an employee, and as a leader in this organization, this simulation was so well planned and so well executed. And no one had an upper hand going into the simulation, which sometimes happens when you walk into a simulation. People go right into role, and all of that was removed. So I think you leveled the field walking into this discussion. And we did have some rich conversation. But I do want to say, one of the observations that I had is that you have one or two people who never spoke at all, never responded. And I know it, at least if you hear the information, you've heard the information and the brain has taken that on. But have you all given any thought about, because everyone won't be verbal in simulations, and as much as the folks try to pull information and tease it out and share, there were a good 2 or 3 people who never said a word. So any thoughts about that?
Yeah, you're absolutely right. I think that's definitely a common occurrence that we see, something that we talked about going in. And I think our primary goal for this kind of initial type, ground level type of training, was to really try to be respectful of what folks were willing to share and not share in a situation like this, and not be assumptive of why they weren't, or why they may not choose to share. In fact, we've seen kind of the opposite. We've had folks reach out to us worried this might trigger something. And we have been cognizant of what we do. We have plans in place. What happens if someone gets triggered to the point of raw emotion? And that's part of the reason we have 3 facilitators there, with breakout rooms enabled. And we consulted with some of our psychosocial folks as well to deal with that. So I think we erred towards that side. Because the sentiment you just brought up has been brought up by some other learners in their evaluations. Why are people not talking? Some people are not talking. And the truth is, we don't know why. And I think it fit with our goals of this training to not force it. There may be trainings where there would be a mandatory reflection or a mandatory something, but I would view those as slightly higher level trainings then. And the nature of this training, that you're in front of your peers, it could be anything from the fact that you do learn by listening, to you don't agree, to you have social anxiety and you would never speak in a Zoom meeting under any circumstances unless forced to. So definitely something we thought about, definitely something that I think that we've noticed as well. And I think for what we currently have, we're comfortable with the amount of talking that typically is going on. But I could see in further levels of training, if we did iDream Part 2 or a secondary level, there would be some form of maybe not verbal reflection, but some part of, hey, please reflect and submit as part of the training, so that at least we are having folks do something like that. But again, it comes down to adult learning versus, pedagogy versus andragogy. Do we want them to submit something, or is it just important that they do it themselves?
And Jeannie, thanks for sending your folks. We've had lots of people from the Richmond Clinic and from ambulatory far and away attending and be very engaged. So thanks for your support.
This is wonderful work. And we have to keep these conversations going. So you all, this is phenomenal work. Thank you all.
I just wanted to add, and Ginny, I think your point is well taken, but and this may sound odd, but I think there's bias in your question, even because I say that because iDream virtual learning is not the only thing the simulation program does, and we have multiple trainings on simulation that are virtually done where no one participates, or some people never participate. And we have meetings where people don't participate virtually. So I think that there's, to Simran's point, we should not make that finding a finding of iDream training, right? That is not, and maybe that this topic for that person is why they're not talking, or maybe they never talk. We don't know the answer to the question, right? And so I think that when people don't participate in the iDream, we walk away saying, okay, they didn't participate. They got out of it, whatever they got out of it. And that's kind of how we have to really understand that when they're asked to participate, they're not volunteering to participate because this is required training. They're asked to be there, that we have to understand that there's probably some factors that may come into play that may impact their participation that have nothing to do with DEI.
Oh, I'm so with you. That's really why the question was, what are your thoughts around this?
I mean, I think I gauge the audience, and sometimes, if you have a big group and a couple people aren't talking, it's not as pronounced as if you have a smaller group and maybe one or two are quiet. And depending on kind of the feel that I get from them, sometimes I might kind of call them by name and just say, like, we haven't heard from you. Is there anything you'd like to share? And sometimes just even being invited will generate a response or, some sharing of an experience. And sometimes they're like, no, I'm okay. And we're fine with that too.
May I thank you all. I have loved this conversation every month. I think, how could the Conway Chair Conversation get any better? And then there's the next conversation. I wanted to remind all of you that we will not be having a conversation in April because it is Research and Education and Innovation Week, and I hope to see you all there. I want you to know that on April 6th at noon, the new director of the National Institute of Nursing Research will be offering the keynote, and she's going to be sharing strategic frameworks that are relevant for this very topic today. And the National Institute of Nursing Research has a large portion of their portfolio that funds the careers of non-nurses as well. I really hope to see all of you there. Particularly thanks for our lead conversationalists today, Heather Walsh and Dr. Simran Sran. Thank you both for the work and for the very scholarly conversation that you led today. See you all in May. Our very best. Please take the best care of each other.